serious problem. Having had pulmonary emboli myself, you know how serious a deep vein thrombosis can be, and it's our job to detect these when present and treat them promptly and adequately. So Dr. Michael Troiano is going to come back and talk to us about DVT risk assessment, diagnosis, and treatment. So let's welcome Dr. Troiano once again.
A good friend of mine, 38 years old, had the flu this past week and went to the hospital and got a shot of Tamiflu when he was sick, and he came home and he was laying around, and that night he had trouble breathing and spit up some blood and was gone within about 4 hours from a DVT that turned into a PE. These things move pretty quickly, and unfortunately we probably, as the podiatric physicians, cause a fair amount of them. Even if you're not doing surgery on someone, think of what you're doing with them. Someone comes in with tenosynovitis, what do? You put them in a cam walker, you put them in a cast, you put them in a soft cast, Uno's boot, what have you. And do we really ask ourselves, is this person a little heavy set? Do they, did I interview them about their family history? How'd mom pass away? How'd dad pass away? People say cancer, but maybe that cancer led to a DVT which killed them. So you really want to get into the meat and potatoes of that patient. Prophylaxis, again, these are the stockings, these are the sequential compression devices, SCDs, that the patient's going to be on in the operating room, and when you admit the patient to the hospital, if you're not working with residents, or you are, you want to make sure that they order them. Low molecular weight heparin, everybody hates Lovenox because I got to give myself a shot in the belly. Well, at least if you prescribe it, that's all that really matters, right? I mean, this person has to know that this is proven efficacy to reducing the incidence of DVT. And I've had patients even get a DVT with using Lovenox, but at least they are treated appropriately. You're giving them what they need to get to the show. Unfractionated heparin has some issues. The cost is a little bit better. Most insurances are covering it, but you have to be aware of this person's creatinine, their kidney function, because it can affect your kidney function. And you have heparin, which is not so much dependent on kidney function, but has to be given more times a day, so the outpatient setting is not realistic. And you have to consider your Xareltos. Direct thrombin factor 10A inhibitors have not been studied in the general surgical population. Warfarin, if you can bridge to warfarin, that person's in the hospital for a little bit. It's not a bad choice. It's very cheap, but you or the primary care doctor or your Coumadin clinic has to monitor it. So it takes a little bit of goings-on, shall we say, so that you're getting those faxes, on a weekly basis, God bless you, or you're getting that patient to report to you their INR after it was drawn. Therapeutic is in between 2 and 3.